Hey guys, it's Joel, and I wanted to upload a quick video about schizophrenia because it's not something that, unless you work specifically with that population, you'll see a ton in private practice or in just general practice therapy. But I mean, it does happen. It's a diagnosis that a lot of people don't know a lot about, they're not very familiar with. And I think in talking to some of my peers, I've been surprised where there are people who aren't catching it when that comes into the clinic, especially in the early phases. People aren't really seeing that in private practice, and it's getting diagnosed as like an obsessive disorder, or a maybe adjustment disorder or something. So I used to work with that population. I just wanted to give you guys a couple little bits of information about how you treat that and also how you recognize it. So I mean, the first thing is, with schizophrenia, what you're going to notice is that the person is going to have obsessions, but the obsessions are going to have a weird theme. So delusions usually start off as obsessions when someone's in that prodromal phase, which is that beginning part of schizophrenia, where they're not in full-blown psychotic split, they haven't had a psychotic break, but they are starting to just kind of have some weird ideas of reference. Maybe, this person did that because of me, or everybody, the reason that this thing is here is because of me, or, this building really is mine, but nobody knows that. Something like that, but everything else seems okay. People can't talk it out of it. They're kind of... Also, the obsessions, usually delusions start off as obsessions. So somebody reads a book, they see a movie, they see a TV show, and then they start thinking like, well, I have to... they start thinking that, hold on, a bee landed on my hand, and I don't want it to sting me. There it goes. So people will have a weird obsession, like... not a weird obsession, but an obsession that's out of character for them. Like, in this comic book, this thing happened, and I can't stop thinking about that. That means these other things are going to happen. That's going to be a chain of events. And it does have that kind of obsessive feeling, but it's more focused on kind of a bizarre assumption that maybe is outside of what their normal intellectual or reasoning capacity would be. So when you see that, I mean, it's a pretty good idea. It's a pretty good idea to kind of start saying like, okay, well, are you hearing voices that aren't yours? Or do you just all of a sudden know things, but you're not really sure why you know them? Or, how did you get there when you're thinking about this? What are the things that led you to believe that? If there's nothing that led them to believe something, if there's nothing that led them to think that, and they just know that it's true, that's a pretty good sign that you're maybe dealing with somebody who's in the prodromal phase of schizophrenia. Schizophrenia can have an onset on it at any point, but it's a rare diagnosis anyway, and it's almost always going to happen with somebody. For adults, for men, it's going to be in between like 25-30. For women, it can be in between 30-35 is the most common onset for those ages. Some people who you may be seeing that have schizophrenia, but all of a sudden they're starting to show symptoms when they didn't before it was well managed. Keep in mind that some people marijuana seems to affect very strongly, where they decompensate quickly. Some people marijuana doesn't really seem to affect at all as far as their symptoms goes. It affects them the way marijuana normally affects them. Other people, if they're on a med like Abilify, sometimes the change in dopamine will make the marijuana high not as much, and so that will be a reason that patients decrease their medication, is because they're not getting as high as they want to if they use marijuana. People who binge drink alcohol, you can drink antipsychotics out of your system. So if somebody's med adherent, yet that you're seeing symptoms in someone that has that diagnosis, you maybe want to find out how much they're drinking. Because you can drink that med out of your system and then all of a sudden start to have those effects. If you've had someone who is having a chronic problem staying adherent on medication, they've tried a couple times, they really seem to grasp it, understand that they need to, but when they miss a dose, this is a thought disorder, so when you miss a couple doses of it, you're going to start thinking in a way that isn't helpful, and then that doesn't help you be proactive and get back on your medication. It makes you kind of lose focus. So, the best history of future behavior is going to be past behavior. That may be a good idea to get on an injection. If you're not familiar with psych meds, you can do an intermuscular suspension, which is a shot that lets the medication stay in your system. for really a month to 3 months, depending on the medication. So if somebody's already on something like a Abilify, a Ripazole, or Risperdal too, and they just continue to go off of it, an intermuscular suspension IM shot is probably a good idea. You can recommend that to them. You can recommend that to their psychiatrist. The shots can be expensive. In Vegas, a stent will last 3 months. I think that's like a $400 shot out of pocket. It's really expensive, but you can a lot of times get a psychiatrist to write a letter making a case to the insurance company that this person is going to be more expensive and that they have some other diagnosis that's going to interfere with their ability to take medication and that they need to have that covered. Other times, it may just make sense for it to be paid out of pocket. I mean, if you're going to fail out of college, if you're going to lose your job, that's going to be a lot more expensive than just going ahead and paying out of pocket for a shot. You're getting the shot 4 times a year. The shots work really well. Not everything is available that way, and the doctors are going to have the person take the medication orally for a couple months to make sure that it's working okay, so that they know that they're going to tolerate the med well. They're not just going to put them on a shot right away. But if they've been on the med for a while and adherence is the issue and you can't seem to reach them through kind of a behavioral modification, I would think about doing the injection. Keeping somebody on one of these medications is going to be the #1 priority if you have somebody who has a psychotic disorder. So I would try and switch to keeping them on that right away if someone has schizophrenia and they're not taking their medication. One of the issues where you run into, and this can also be an issue with other people that are on things like Risperdal or Abilify or Depakote for bipolar, for OCD, for other diagnoses too, is that their appetite all of a sudden increases. They don't know when they're full, or they get really hungry all the time, and they gain a lot of weight, and then they don't want to be on the medication anymore, so they don't see their doctor, they just quit taking it. I've had that happen with lots of patients, and there's 2 medications that are anticonvulsants that are prescribed off-label to adjust the hunger side effect for antipsychotics. I would suggest that to the patient and suggest that to the psychiatrist, because I've had a lot of people that are able to stay on their medication just because we were able to, it worked for them, it worked well, but they didn't want the appetite side effect. Just because we were able to adjust that and they could take it. So those 2 meds are Zonisamide and Topamax or topiramate. Those are a way that you can keep a patient on a mood or on one of the OCD, bipolar, or schizophrenia medications without that hunger side effect. So look at those. Definitely suggest that to a psychiatrist because not all of them know. And the other thing is that you really want to act quickly with anybody that has a schizophrenia diagnosis to get them stable, because what happens is that this is my level of functioning. I have a psychotic break. If I can't prevent that, if you catch them in the prodromal period in therapy, you can get them on a medication before they have a psychotic break, which is the #1 thing. But if I have a psychotic break, then my level of functioning just crashes down here. I go back on the medication, it comes back up. Then I go off the medication, it crashes again. Then I get on the med, it comes back up. But each time, it's not quite coming up to where it was before. So you have somebody who's going to decline in functioning if they're going on and off medication for a long time. And you know, we want to catch all of these things before they're permanent. There's not a ton of conditions that you as a therapist can jump in and make sure that they aren't permanent. I mean, addiction and schizophrenia are maybe 2 of those cases where if you're able to work with a patient to get them where they need to be, you can prevent, you know, permanent deficit in functioning. So it's really important that people know a little bit of information about this, because I don't know that all the LPCs and social workers get a lot of that in school. I hope this is helpful. If you have any questions, just let me know, and I hope y'all are doing well.